Hi there, it's Dr. Atkinson. Welcome back. This is part 2 of our lecture on assessing respiratory function. If you haven't gone through part 1 yet, go ahead and do that first. In that session, we laid the groundwork, taking a good history, recognizing normal breath sounds, and paying attention to visible signs of respiratory effort. Now we're going deeper. In this class, we're focusing on abnormal findings, what they look like, sound like, and what they mean. We'll also cover percussion, bedside measurements, and the numbers you need to know. Let's jump in. Objective assessment and physical exam. Once you move from history into the hands-on assessment, you're engaging all your senses: sight, hearing, touch, and yes, even tapping. Start by observing the patient. Watch the chest rise and fall. Count the respiratory rate for a full minute. Don't shortcut that. Pay attention to whether their breathing is shallow or deep, regular or irregular, fast or slow. Are they using accessory muscles? Are they nasal flaring? Is one side of the chest lagging behind the other? Next, auscultate. Place your stethoscope on the patient's chest and listen carefully to each region, comparing side to side. You're identifying normal breath sounds, vesicular, bronchial, or bronchovesicular, based on where you're listening. But even more important, you're listening for what doesn't belong. Let's talk about adventitious sounds. Wheezes are high-pitched and musical, often heard with asthma or narrowing of the airways. Crackles, also called rails, sound like little pops or Velcro being pulled apart. These may point to fluid in the alveoli or collapsed airways that are reopening. Raunchy are lower-pitched, snoring sounds that often suggest mucus or obstruction. Pleural friction rubs are harsh and grating, like two pieces of sandpaper rubbing together, indicating inflammation of the pleura. And stridor, that high-pitched sound heard on inspiration, is a red flag. It usually means upper airway obstruction and needs immediate attention. Then there's palpation and percussion. You want to feel for symmetrical chest expansion and check for tactile fremitus. Place the palms or ulnar side of your hands on the patient's chest and have them say 99. You should feel the vibrations. If it's increased, that could mean consolidation like pneumonia. If it's decreased, it could suggest a pleural effusion or pneumothorax. Percussion is tapping the chest wall to evaluate the underlying structures. A resonant sound is normal and indicates air-filled lung. A dull sound may suggest consolidation, atelectasis, or pleural effusion. A hyperresonant sound could be a sign of trapped air, like an emphysema or pneumothorax. It may feel old school, but percussion can give you real clues, especially in patients with limited imaging options. Clinical patterns and what they mean. Let's go through some common patterns of assessment findings and break down what they tell us. I don't want you just memorizing charts. I want you understanding what these clues mean in a real patient. Normal lungs will be resonant on percussion. Breath sounds are vesicular, the trachea is midline, fremitus is present and symmetrical, and there are no adventitious sounds, or maybe just a few soft crackles at the bases in older adults. Chronic bronchitis usually still has resonant percussion, but you may hear coarse crackles, wheezes, or raunchy. Fremitus doesn't typically change. Early heart failure might still sound resonant, but you'll often hear late inspiratory crackles at the bases. Fremitus stays normal. In lobar pneumonia, you'll hear dullness to percussion, increased fremitus, bronchial breath sounds over the consolidated area, and late inspiratory crackles. You might even hear bronchophony, egophony, or whispered pectoriloquy if it's severe. Atelectasis, that's a partial collapse of lung tissue, will give you dull percussion, absent breath sounds over the area, decreased or absent fremitus, and sometimes a tracheal shift toward the affected side. With a pleural effusion, percussion is dull or flat. Breath sounds and fremitus are decreased or absent over the fluid, but you may hear bronchial sounds just above the effusion. The trachea may shift away from the affected side. Pneumothorax, that's air in the pleural space, sounds hyperresonant or even tympanic. Breath sounds and fremitus are absent, and the trachea may shift away if the pneumothorax is large or under tension. COPD often has hyperresonant percussion, decreased breath sounds, prolonged expiration, decreased fremitus, and wheezes or crackles scattered throughout. In an asthma exacerbation, percussion may be resonant to hyperresonant. You'll hear prominent wheezing and maybe some crackles, but often the breath sounds are masked by the wheezes. Fremitus is decreased. bedside respiratory measurements. Let's move from stethoscopes to numbers. These values give you concrete data on ventilation and lung mechanics. Respiratory rate is your first and most basic vital sign. Always measure it, never estimate. Tidal volume is the amount of air moved in and out with each breath. You measure it with a bedside spirometer. Since it varies from breath to breath, you need several readings to get a reliable average. Minute ventilation is tidal volume multiplied by respiratory rate. It gives you a sense of overall ventilation per minute. If it's too low, the patient may be retaining CO2 and becoming acidotic. Vital capacity is the maximum amount of air the patient can exhale after a full inhalation. If the value is under 10 milliliters per kilogram of body weight, that patient may not have enough muscle strength to sustain breathing on their own. Forced vital capacity, FVC, and forced expiratory volume in 1 second, FEV1, are key in evaluating obstructive diseases. If the FEV1-FVC ratio is under 85%, think asthma or COPD. Finally, inspiratory force tells us how strong a patient can inhale. We measure it using a manometer. You briefly occlude the airway and the patient generates negative pressure. A normal value is about 100 centimeters H2O. If it's less than 9-25, the patient may need mechanical ventilation. Why this matters. Here's why all of this is so critical. Patients who are older, obese, just out of surgery, or under sedation may not be able to fully expand their lungs. They start breathing more shallowly. Tidal volume drops. And when that happens, alveoli start to collapse. This is atelectasis, the perfect setup for hypoxemia and pneumonia. The body tries to compensate by breathing faster, but that doesn't fix poor gas exchange. It just wears them out. So when you assess respiratory function, you're not just checking a box. You're looking for red flags before the patient starts spiraling. Assessment leads to intervention. That's your job. Quality and safety alert. Let me leave you with this nursing alert. Do not rely on chest movement alone to determine whether a patient is adequately ventilating. They may be moving air in and out of their upper airway only, never reaching the alveoli. Use your ears. Use your numbers. Use your pulse oximeter and capnography when available. That wraps up part 2 of our respiratory assessment series.